Thank you very much indeed. It's a real pleasure to introduce you to this video, who was made by our fellows in the School of Emergency of the University of Pavia. They did an excellent job in this pandemics, because they realized as soon as we started to be in the middle of this battle with our hospital, that, as you know, the hospital of Pavia is one of the epicenter of the epidemics here in northern Italy. And these fellows were very smart in designing the possibility of applying lung ultrasound to all these patients. Very quickly, this approach became a standard of our approach to these patients, and we found several very interesting things that helped us a lot in the clinical evaluation of these patients. As you will see, some of the results of what we applied will be presented at the end of the video. I wish to thank very much the 4 fellows who did this wonderful job, namely Gianmarco, Lorenzo, Caterina and Marzia, and I wish to thank Bianca for giving the voice in the English setup. Everybody took a place here, and I cannot forget to mention the wonderful job that Giancarlo Gini, a colleague of us who is now in Varese, who did a few years ago, introducing our fellows through the School of Ultrasound, that is the school of the CIMEO Association, to our fellows. Basically, they started working with them, and they started working with this team in order to get introduced to this technique. Basically, in the video, they will track some of the main features that are very important in setting the machines, in trying to approach the patient, in trying to be as systematic as possible in order to use this in the real setting of the emergency room. Last but not least, the possibility of doing lung ultrasound is very important in the setting of an epidemics, because the patient is not moving from one side to the other, and so the possibility of diffusion of the infection is limited. I hope you will enjoy this presentation that is a contribution to our fight towards COVID-19. Thank you very much.
Hello everybody, I'm Bianca Giacomuzzi-Moore, an ex-University of Pavia student and trainee, currently working as a resident in internal medicine in Switzerland. Today, I will present to you a project that has been carried on by the emergency department residents of the Policlinico San Matteo in Pavia, concerning the use of the pulmonary ultrasound in COVD patients. COVID-19 is a respiratory infectious disease caused by the SARS-CoV-2 coronavirus. The first cases of COVD have been detected in December in China, in Wuhan city. The infection has then spread rapidly in what is now considered a world pandemic, affecting the global health system. As to the 24th of March, 400,000 cases of COVID-19 have been registered in more than 190 countries in the world, and the number of affected people is still rising. Italy is the second country to be affected after China, with 70,000 cases. The clinical manifestations of COVD are variable, from mild flu-like and self-limiting symptoms to an interstitial pneumonia that can rapidly evolve to ARDS, an acute respiratory distress syndrome, to multi-organ failure and possibly death. Being a pathology that predominantly affects the respiratory tract, pulmonary ultrasound has become an essential instrument for the early diagnosis of this disease. Basic ultrasound can in fact allow bedside evaluation of the patient and has a higher sensitivity than radiography in recognizing pulmonary involvement of the disease. It has been demonstrated to be of a diagnostic power comparable to a CT scans. It is rapid and can be used to monitor the clinical evolution of the patient and his response to treatment. San Matteo Hospital in Pavia is one of the main reference centers for COVID-19 Italian pandemic. The GERICO, Gruppo Esteso di Ricerca Coronavirus, meaning Extended Group for Coronavirus Research, was therefore born. For every patient affected by COVID-19, we perform pulmonary ultrasound and collect the medical history and clinical and laboratory data in order to improve the diagnostic approach to this disease and obtain information that can help us evaluate the patient's prognosis. So let's see how an ultrasound is performed. First of all, let's begin with the instruments. Therefore, the ultrasound machine. Here you can see 2 common ultrasound models. If you perform ultrasound in an emergency setting, it is very important to have general knowledge of the machine we have in front of you. First of all, let's start by selecting what is called a preset and by choosing the probe. In thoracic ultrasound, all types of probes can be used. Anyhow, the mostly used probes are the convex and linear ones. The convex probe has a low frequency of the ultrasound beam emission, going normally from 2 to 5 MHz. This is considered a low frequency probe, meaning that it is able to penetrate the tissue at a greater depth. This is therefore the correct probe for the study of deeper organs and in general parenchymal tissues. When performing a pulmonary ultrasound, this probe will therefore allow us to evaluate the pulmonary parenchyma, but will also be less precise for the evaluation of more superficial structures like the pleura. The linear probe, on the contrary, is a high-frequency probe. It has very high resolution of the image, but is less powerful as far as penetration power. Therefore, for pulmonary ultrasound, its results should be useful for the evaluation of superficial structures, especially the pleural line. For our project, we have chosen to use the convex probe as in the emergency room it allows us to evaluate different structures in the shortest amount of time and offers a wider scanning window. But let's go back to the ultrasound machines. Here you can see two different models. Each model has a different configuration, but similar characteristics. Once chosen the preset and the probe, what should we necessarily set next? The same attention has to be put in ultrasound performance as when you're taking a good picture. Therefore, luminosity, distance from the subject, and most importantly, focus, need to be taken into consideration. In red, we have identified the gain button that allows us to increase or reduce the intensity, also called gain. The button that allows us to regulate the depth is identified in light blue, while in yellow and in green we can respectively identify the trackball and the buttons for the main menu's ultrasound settings. When performing a pulmonary ultrasound, it is necessary to set the focus on the pleural line and to regulate the depth of the image. One thing to keep in mind is that pulmonary ultrasound is an imaging method that receives a lot of information from the artifacts rather than from direct, clear images. We will therefore perform longitudinal scans of the thorax. We will find the pleural line that will appear as a hyperechogenic line, therefore white. Normally, the pleural line moves, and the two sheets of pleural tissue slide one over the other, generating what is defined as a pleural sliding, which is a sign of correct pulmonary ventilation. In the image, we can also see two black signs, which are the two rib shadows. In the middle of the two shadows, we can visualize the pleura and the pulmonary parenchyma. This is called a bat sign, where the pleural line is the body of the bat and the two black shadows the wings. It is possible to perform transversal scans by putting the probe over the intercostal spaces. This allows you to eliminate from the image the rib shadow and to obtain a wider image. This scan is necessary for a more thorough study of the lung parenchyma and the pleural line. Various pulmonary ultrasound techniques exist, and these are chosen depending on the medical context they're applied in. In emergency care, the mostly used technique is the 12-field one. 6 scans of each hemithorax will be performed. 2 anterior scans, 2 lateral scans, and 2 posterior scans. As you can see in the image, the parasternal lines and anterior axillary lines delimit the anterior fields. The anterior axillary line and the posterior axillary line delimit the lateral field. The posterior field is delimited by the posterior axillary line and the paravertebral line. The 3 regions, anterior, lateral, and posterior, are further divided in superior and inferior fields, therefore for a total of 6 fields for each lung. When performing pulmonary ultrasound, we can find different scenarios. Moving from left to right, we will observe a progressive increase of the liquid percentage in the lung. In the first image, we see a normal lung, characterized by A lines. These are horizontal artifacts parallel to the pleural line that originate from its reverberation, meaning its artifactual repetition. In this lung, the ventilation percentage is of nearly 100%. As the air-liquid ratio diminishes and the liquid content of the lung increases, B lines start to appear. These are vertical artifacts that are perpendicular to the pleural line. In the second image, we can see sparse B lines and we can still recognize A lines. In the third image, multiple B lines can be seen that erase all of the A lines. This image represents what is defined white lung in pulmonary ultrasound. In the last image, we see what is called an hepatized pulmonary parenchyma, in which the air content is practically non-existent. We will close this chapter of our presentation with a quote from our mentor. Every ultrasound specialist has to approach the exam with a critical mindset, in order to interpret the image based on the clinical presentation of the patient. Therefore, as the wise say, before turning on the ultrasound machine, let's remember to turn on our brains. COVID-19 pneumonia is generally an interstitial pneumonia, usually multilobar, that can rapidly evolve in IRDS, acute respiratory distress syndrome. The ultrasound findings in these patients evolve with the disease and go from an interstitial pattern that can also interest only one lobe with a typical white lung and some subpleural consolidation. Consolidations can be of variable dimensions. These can also degrade and evolve into what we previously defined as pulmonary hepatization. COVID-19 pneumonias are most frequently localized in the posterior and inferior fields, but there are usually no fields that are spared from the phlogistic process. B-lines are often in a fixed position. The pleural line is usually irregular and discontinuous, and often interrupted, not only by the presence of subpleural consolidations, but also because it often appears as if it is damaged. Furthermore, the sliding is reduced. Surrounding the lesion, we can also sometimes find a minimal localized pleural effusion. We can here see some representative images. In both these images, we can find an interstitial syndrome that occupies more than 50% of the pleural line. In the first image, top left, the pleura appears finely irregular. In the second one instead, the pleura is fragmented, and we can see a small initial subpleural consolidation. On the left, we have another interstitial pattern with a fragmented and irregular pleural line, associated to multiple subpleural consolidations. On the right, we have a representation of a wider parenchymal consolidation that, as you see, extends itself deeper into the lung. Here as well, the pleural lines looks irregular and thicker. As we previously said in the San Matteo emergency room, we mainly focused on executing pulmonary ultrasound in patients that are highly suspicious of COVID-19 infection. The first examination is performed at time 0 upon first access to the hospital. If the patients are hospitalized, we try to perform, where possible, ultrasound monitoring in the in-hospital patients and departments in order to evaluate the progression and evolution. The results are properly charted. Patients are registered inserting in the charts name, surname, sex, and date of birth. We have chosen to use the convex probe at a 5 MHz frequency. This because it is accessible on all ultrasound machines of our hospital. We then set the depth to 10 centimeters. Obviously, the ideal depth would be 8 centimeters in order to visualize the pleural line with higher resolution, but in the majority of overweight patients, this is not possible because of the thickness of the subcutaneous tissue. We are then going to set the gain to about 50%, but this can also vary according to the ultrasound machine. Let's then set the focus on the pleural line and proceed to the acquisition of the image. In order to standardize the method of image collection, we decided to follow a predefined order, as inserting a body marker in every clip would have been wasteful and costly in terms of time. Let's start from the right lung then, with the scan of the supero-anterior field with an intercostal positioning of the probe. Let's then move to the infero-anterior field. We will then scan the lateral ones. We will then move to the contralateral lung, the left one, analyzing the same 4 fields and therefore obtaining the first 8 scans. Leaving the patient in supine position, we are then going to evaluate the subcostal window, looking for pericardial effusion and evaluating inferior vena cava. In the end, where possible, we are going to position the patient in a sitting position, and we will perform the first posterior scans starting from the right hemithorax. In this picture, the representation of what was just explained. Special thanks to our model Max and the ultrasonographist Marco Bonzano. We will now talk about the data recording concerning the registered patterns and the LUS score. This score gives us insight regarding the degree of ventilation of the pulmonary parenchyma. It is obtained from the sum of the scores given to every single field in a range going from 0 to 3, depending on the ultrasound results. This has been validated from our intensive care colleagues and prevalently used in the intensive care unit. Pattern 0 represents a normal lung, with A lines on the whole field or up to 2 separate B lines, which are not considered pathologic. Pattern 1 represents a lung in which 3 or more distinguishable B lines can be seen and that occupy less than 50% of the pleural line. Pattern 1 also comprehends subpleural consolidations of small dimensions. As for small, we refer to consolidations that occupy less than 50% of the pleural line. Pattern 2 is the most frequently found pattern in patients with COVID-19 pneumonia that need oxygen therapy. This represents a lung with a highly reduced ventilation degree, therefore with B lines occupying more than 50% of the pleural line, which could go up to a white lung scenario. Subpleural consolidations that occupy more than 50% of the pleural line of the field we are investigating are also considered to be part of a pattern 2. Pattern 3 is the terminal stage. Here, the lung has lost its ventilation and therefore looks highly consolidated with a clear bronchogram, or even hepatized. We have added to this score the pleural line evaluation, which in our charts we mark with an asterisk. In these images, you can see the graphic representation of what was previously said. On the left, a completely ventilated lung, and on the right, a lung with a tissue-like pattern, in which it has lost all of its ventilation and looks like a visceral organ parenchyma. Here, you can see an example of LUS score. A score of 18 indicates an already highly compromised lung. Here are a few short clips that we recorded in our emergency room performing ultrasound at time 0 in COVID-19 suspected patients upon arrival to the hospital. Here, you can see a normal lung with a regular and smooth pleural line, preserved pleural sliding, and normal A lines. Here, we can see a pattern 1. We can visualize B lines that occupy less than 50% of the pleural line. Both these clips are representative of a pattern 2. On the left, we can see a very irregular pleural line, associated to a diffused, non-homogeneous interstitial syndrome and subpleural condensation. On the right, a clear white lung in which the ventilation percentage is most probably inferior to the previous clip. In this last clip, we see the image of a pulmonary base. We recognize it from the presence of the diaphragm, which is frankly condensed, nearly hepatized. In these images, if we focus on the pleural line, we can see how this looks clearly irregular. We can anyhow see a few spared areas in which the pleura appears normal.
We now try to show you what are the diagnostic and prognostic yields of this technique when applied to a situation like the present one with the COVID infection. Thank you again to our wonderful fellows of the fellowship program in emergency medicine. We performed lung ultrasound in 100 patients who were COVID positive at the swab. As you can see here on the left, the chest X-ray was suggestive only in 25% of the patients. It was suspected, that is a gray area, in 35% and negative in almost 40% of our patients. On the right, you can see what are the results of lung ultrasound score. As you can see, 80% were positive when using a cutoff of 4, and more than 90 were positive when using a cutoff of 1. Only in 10% of the patient it was possible to see a negative result. Moreover, the last score was correlated with the P/F or over F ratio, that is an indication of the severity of the disease, and the last score was also prognostically valuable. As you can see, the survival in patient having a last score more than 4 was significantly worse than the survival in the other patient, once again underscoring the role of this technique. Last but not least, we tried to see what was the prognostic possibilities associated with the last score. As you can see in these 4 rock graphs, basically the last score was sensitive and specific for identifying the patient who needed CPAP on the top in the left panel, who needed an intensive care unit approach and admission on the right panel. On the bottom, you can see on the left the combination of intensive care unit admission or mortality in these patients. once again underscoring how the last score that was performed when waiting for the swab results was predictive of the worst complication in this disease. Another very important point, as you can see in the bottom right panel, the last score was also very useful in identifying patients who needed emergency room discharge. A last score that was lower than 6 was able to predict the patient who could safely be discharged from the emergency room, sent home on quarantine. Once again, thank you very much for the opportunity of having had this group of students who were wonderful in designing this teaching tool that I hope you will appreciate. Thank you very much.